Hi, my name is April Whitaker, and this is a presentation on Parkinson's disease for the age group of 65 and older. Parkinson's disease is a slow progressive neurodegenerative disease process that destroys dopaminergic neurons within the substantia nigra of the brain. Dopamine is a chemical messenger in our brain that allows for the ability of smooth coordinated muscle movement. And by the time a diagnosis of Parkinson's is made, up to 80% of the dopamine containing cells have already been destroyed. The damage, unfortunately, is irreversible and there is no cure. 90% of the cases of Parkinson's are idiopathic in nature, with symptoms beginning to present themselves around the age of 60. The other 10% are a result of an inherited gene, and symptoms usually start around the age of 45 or younger for that particular group. The diagnosis of Parkinson's disease is based on symptoms of the individual, a clinical examination from the primary care physician, and a complete medical history. There is no diagnostic test or lab test that can be done to diagnose Parkinson's at this time, other than an autopsy upon death where they check for the confirmation of Lewy bodies within the brain. To diagnose an individual with Parkinson's disease, the person needs to present with 4 specific symptoms, and they use an acronym called TRAP, T-R-A-P, to assess for these 4 symptoms. It's tremors at rest, rigidity, akinesia, and postural instability. And these 4 symptoms are considered the cardinal signs of Parkinson's disease. Parkinson's disease is the second most common neurological disease of the elderly, and due to the development of sleep disturbances, cognitive impairment, and reduced facial expressions from Parkinson's, it often goes underdiagnosed. Risk factors for Parkinson's disease include modifiable and non-modifiable risk factors. The non-modifiable risk factors for Parkinson's include age, gender, genetics, culture, and ethnicity. Age is the most predominant risk factor for developing Parkinson's disease. The older that we get, the higher the risk is for developing Parkinson's disease. Males are twice as likely to develop Parkinson's disease over women, particularly Caucasian males and Hispanics, although males in any culture or ethnicity have a higher incidence rate for Parkinson's. Modifiable risk factors include the prevention of traumatic brain injuries. It's been shown that individuals who experience repeated traumatic brain injuries have a higher risk for developing Parkinson's disease later on in life. And geographically, there's a lot of areas within the United States that kind of predispose an individual for the risk of developing Parkinson's disease. Nebraska actually has the highest rate of Parkinson's disease in the United States. Living in rural areas, particularly like your farmers, have a higher incidence of Parkinson's, and the belief is it's the exposure from pesticides and herbicides, although there hasn't been a link yet connecting Parkinson's with exposure to those. Multiple studies have been done, but yet the incidence of Parkinson's disease remains high in these particular areas. Also, living in the northeast and midwest regions of the United States also increases your risk for developing Parkinson's. And this little portion of the United States actually has a name called it's called the Parkinson's Belt. The belief there too is exposure to industrial pollutants from the industrialized areas. It predisposes a person for developing Parkinson's disease as well in those areas. The formation of Lewy bodies is considered the pathological hallmark of Parkinson's disease. And the formation of Lewy bodies is a result of the aggregation and formation of abnormal folding proteins in the brain, particularly the A-synuclein protein. Identification of Lewy bodies, again, can only be done through an autopsy. And they can be found throughout the central, enteric, and peripheral nervous system. And on this picture, you can see what a Lewy body looks like, and the reddened areas are where Lewy bodies can be found within the brain. Parkinson's disease can affect, any portion of the brain, and the types of motor and non-motor symptoms are dependent on where the lesion formations occur within the brain or other portions of the nervous system. The substantia nigra is the primary source for lesion formation of the Lewy bodies, and you can see where that's located on this picture, kind of in the lower mid center of the brain there. Lesions may also develop within the thalamus, hypothalamus, cortex, brainstem and spinal cord, the olfactory bulb, and the sympathetic and mesenteric plexus of the gastrointestinal system. The symptoms of Parkinson's disease can be divided into two categories, motor and non-motor symptoms. And on this slide, you can see the list of non-motor pathophysiological changes that occur with Parkinson's disease. Many of these changes you're not going to notice in the patient until the later stages of Parkinson's, and they're not going to all show at once. And as you look at this slide, you're going to see that there's a lot of cognitive changes. Depression occurs in over 50% of Parkinson's patients. You can have anxiety. Dementia, particularly Lewy body dementia, develops. They can have weight loss. Drooling usually occurs towards the later stages of Parkinson's. Fatigue, constipation, urinary incontinence. Symptomatic postural hypertension is a big symptom that many Parkinson's patients develop. And then just overall fatigue, sleep disorders, and excessive daytime sleepiness occur along with dysphagia towards the later stages of Parkinson's. The motor pathophysiological changes are the first symptoms to manifest during the early stages of Parkinson's disease. And these are the symptoms that most people tend to associate when they think of someone who has Parkinson's. You have that slow shuffling gait, the stooped posture, the tremors at rest, those kinds of symptoms. Parkinson's patients develop what's called bradykinesia, which is, it describes the slowness and difficulty in initiating movements. And then you have hyperkinesia, which describes the overall decrease in gross motor movement, such as with your arm swinging when you ambulate. Reduced facial expressions is also another form of hyperkinesia. You kind of see that deadpan face with your Parkinson's patients. And then you have your muscle stiffness and rigidity that begins in the legs, along with muscle tremors at rest that tend to resolve once the individual starts moving around and has purposeful movement. Once an individual is diagnosed with Parkinson's disease, a treatment plan is started that includes therapies such as physical therapy and occupational therapy, along with medications for symptom management. Physical therapy is used to help the individual improve their balance and mobility with walking to help with fall prevention. Occupational therapy helps to facilitate and promote independence with activities of daily living. Speech therapy is used to assess and provide treatment for the development of dysphagia and any swallowing and chewing difficulties that arise as a result from Parkinson's disease. A dietitian is used to help provide nutritional support and assist with the non-motor symptoms of loss of smell and taste that can occur with Parkinson's, as well as talk with the patient about food choices to help prevent nausea and constipation. A referral to a urologist may be needed to assist with urinary incontinence that can occur, and a referral to a psychologist may be utilized to assist with any psychosocial issues that develop throughout the disease process and can be used for both the patient and the family. Many medications are used for the symptom management of Parkinson's disease. The medications used to help stimulate the dopamine receptors and enhance the concentrations of intracerebral dopamine within the brain are your medications such as levodopa, MAO inhibitors, your dopamine agonists, and your catechol or methyltransferase inhibitors. These medications help reduce the motor symptoms such as the tremors that Parkinson's patients have. Vasopressors such as midodrine can be used to help prevent the orthostatic hypertension that occurs, and laxatives can be used for treatment of constipation. Tricyclic antidepressants and serotonin reuptake inhibitors are the primary treatment for depression, and clozapine is used if needed for psychotic episodes. Antipsychotics and antiemetic medications, particularly Reglan, are avoided at all costs with patients with Parkinson's because they tend to potentiate the motor effects, particularly like the tremors. Stimulants such as modafinil or methylphenidate are prescribed to help counteract the daytime sleepiness that can occur, and then sleep aids are used to help the patient sleep at night. Regular monitoring for effectiveness of medication is essential for the treatment of symptoms for Parkinson's disease. As the disease process progresses, adjustments in medications will be needed to help continue to control the symptoms. Eventually, the medication will become ineffective as doses are maxed out and the progression of the disease process nears end stage. Dopamine is a neurotransmitter that is produced in the substantia nigra and the ventral tegmental areas of the brain, as well as the arcuate nucleus of the hypothalamus. The chemical dopamine has many functions within the brain, including assisting with movement, attention, behavioral and cognition, memory, sleep, and mood, learning, and the processing of pain. A deficiency or excess of dopamine is responsible for many disease processes, including Parkinson's disease. In Parkinson's, a deficiency of dopamine causes motor movement to become delayed and uncoordinated and causes an increase in pain. In this picture, you're able to compare the dopamine levels of a normal brain, which you'll see in the top images there, and in a patient with Parkinson's, both pre-treatment and post-treatment. And you can see, if you look at the post-treatment images, the increased areas of red, those are your dopamine areas, and you can see much improvement in those with treatment of medication. This concept map for Parkinson's disease illustrates the motor and non-motor pathophysiological changes that occur with Parkinson's disease, the risk factors and treatments and considerations for care of the patient. As there is no cure for Parkinson's disease, focus shifts to maximizing quality of life and providing supportive care to the patient and family. When caring for individuals with Parkinson's disease, the three areas of primary care, secondary care, and tertiary care need to be considered both in the healthcare setting and in nursing intervention. For healthcare services, your primary care involves the screening for high-risk individuals who may be at risk for developing Parkinson's disease and providing education surrounding the modifiable risk factors. Your secondary care is aimed at reducing the impact of the disease process and beginning symptom management once the diagnosis of Parkinson's has been made. As there is no cure for Parkinson's disease, the goal is to maintain function and independence for as long as possible. The treatment of modifiable symptoms begins with medications and therapies. Education is provided regarding treatment plan, medications, disease process, and fall prevention. Education needs to be provided to both the patient and family. The focus of tertiary care is the management of long-term complex health issues with the focus on improving overall function and quality of life for the remainder of their life expectancy for Parkinson's. This will include the formation of interdisciplinary teams for the development of long-term treatment plan, the continuation of therapies, ongoing education on disease process and medications, referrals to support groups for both the patient and family, especially the family, to help reduce caregiver stress, and then provide support through home health care services. The evaluation for placing the individual in a skilled nursing center will also need to be done at this stage as well. And discussion concerning advanced directives and end of life should begin at the onset of the disease process while the patient is still cognitively aware and able to participate in the discussion. Support services from hospice should be implemented when the individual nears end of life. The focus of nursing care at the primary setting is to focus on assisting with the screening process for high-risk individuals and to reinforce education on modifiable risk factors for Parkinson's disease. For the secondary level, nursing care involves providing education on disease process, medications, fall prevention, and treatment for symptom management of Parkinson's disease. The nurse will also need to assist with setting up therapies and provide emotional support to the patient and family. The nurse should also be included as part of the interdisciplinary team for discussion of symptom management and long-term care of the patient. At the tertiary care level, the nurse is responsible for providing ongoing assessment and treatment as a home health nurse or a nurse in a skilled nursing facility, and promoting independence and quality of life of the individual. Assistance with referring patients and families to support groups in the area, and providing emotional support and pain management and comfort at end of life are also part of the responsibility of the nurse at the tertiary care level. The advancements of technology has allowed the medical field to be able to treat disease processes in a much more effective and efficient manner. With Parkinson's disease, one of the technological advancements is the use of a deep brain stimulator. The stimulator is implanted into the brain near the subthalamic nucleus, and it's used to help treat tremors and dyskinesia that occur in Parkinson's patients. Another technological advancement is the use of telehealth. The use of telehealth allows the primary care physician to be able to assess the patient and speak with the patient who lives hundreds of miles away and is unable to get to the doctor's office. Currently, speech therapy is utilizing telehealth for the treatment of Parkinson's patients, and they're finding that it's just as effective as a face-to-face encounter. Immunotherapy for neurodegenerative diseases is also being explored for the development of a vaccine to prevent Parkinson's disease. The vaccine will target the A-synuclein protein to prevent the formation of Lewy bodies. Stem cell research is also ongoing in an attempt to regenerate dopamine neurons to replace the damaged neurons resulting from the disease process in Parkinson's disease. The internet has opened doors for individuals to do self-education on disease processes, medications, and treatments for various disease processes. It also has provided an avenue for finding support groups either to attend in the community or online through Facebook, Twitter, blogs, or other such internet social media. There are approximately 1 million Americans who have Parkinson's disease today, and 7 to 10 million cases reported worldwide. 60,000 new cases will be diagnosed annually in the United States alone. By the year 2030, the number of Parkinson's cases is expected to increase by 50%. A multidisciplinary approach and patient-centered care is fundamental to promoting independence and maintaining the quality of life for as long as possible. Modifiable factors will become untreatable, and all treatment will ultimately fail. As there is no cure for Parkinson's disease, code status and a discussion surrounding end of life should occur early on in the disease process. Continual support for the patient and family will be needed throughout the entire disease process. Thank you so much for listening to my presentation, and I hope that you've learned many things today. Thank you.